we were talking, probably we have just concluded with thin endometrial because I don't want to concentrate more on the topic, but definitely I would like to talk on the platelet. Only when we are talking as a platelet, as a drug molecule, there are two concepts. One is an autologous, when we use an autologous from belonging to the same patient, and second is an allogenic from the other sources. The best part to understand about this is that platelets are anucleated cells. They don't carry DNA and genetic materials. But definitely, the single donor, when we talk as a platelet, in case of any medical disease like malaria or dengue to transfuse, we always prefer to have single donor because the wall of the platelet contains a protein which is called the histone and its group of proteins. So when we repeatedly use allogenic platelets, it may chronically give some antibody formation, which is again a responsible cause for the repeated pregnancy failure. So platelet as a total, as I told you before we go ahead, we should know the platelet, its biology is very important. Biology of the platelet. The biology of the platelet speaks to you about the cocktail. Okay. Audience, probably you have missed some of my presentation due to interruptions and voice. In fact, there is a request like I should start from again. So that's a good part, but I'll take a brief note to start with again, and then directly I will not talk much of the on endometrium, but I'll take directly the platelets. Dear friends, in the last week, were infertility and the role of regenerative medicine. And I'm very keen as a fascinated person in the regenerative medicine to start this topic as a weekly basis for you. By profile and training, I'm a neurosurgeon, and last 10 years I have been in regenerative medicine. For today's digital platform to reach you, for me, my team who is working IT, Manikanta, Thyaga and Siddhi, I especially thanks to them to make you connect to you. The last 1 year has been like a pandemic year, and we have been at homes. But we also know, in spite of being at homes, this digital platform through various webinars or Facebook or various kind of Google platforms, we are connected to each other, and the small auditorium rooms of conferences were converted into major global conference platforms, and we could reach across the boundaries without moving from one place. That's a good part we have to take from the COVID or from the pandemics. But at the same time, when this pandemic is happening, there is a large growth of pandemic which is seen in the form of infertility experts due to various lifestyle problems of ovarian as well as endometrium. I will be really happy to take you further ahead from a standard medical care to the next edge of medicine, that is the future science, where the various topics related to regenerative medicine used in infertility, particularly on ovarian failures, primary or secondary. Then also there could be an immunological role in pregnancy, then thin endometrium related to immunity. Then also we can have a lot of talk on conceptions in PCOS, how do we go ahead, on how to regenerate the ovary in an aging woman. These are various other topics. Then repeated pregnancy failures, I'll take it one of the top as well. I'll take you a wonderful part of it, that the cosmetic part of the regenerative medicine in regenerative, particularly cosmetic gynecology, which is for young as well as aging women to maintain their ageless life in spite they grow old. That's ageless youth. These are various topics I would like to discuss with you in the coming weeks. As well, an antibody, which is also a very important role in addition to thin endometrium in cases where the repeated pregnancy is playing a significant role. One of the talk, I'll also take you to bone marrow composition in cases where post-chemo, post-radiation or after the cancer treatments where the patient suffer from ovarian failures as well as endometrial fibrosis. How do we do that? Having only a good quality egg or an embryo is not sufficient for engraftment. We need to have fertile soil, and endometrium plays a fertile soil. And we have to see how these dynamics of the endometrium are constantly changing with the dynamics of science, because endometrium is continuously in action, and as such science is also dynamic. And then how do we use this science of regenerative medicine or stem cells in the treatments with thin endometrium, where most of the cases I have seen up to 30 to 40% of the success with most of the infertility experts. This platform is bringing to these experts close to understand we can achieve highest possible fertility rate using regenerative medicine. We cannot forget, reproductive organs are based on reproduction of the genesis of the human life. So the regeneration is the highest potential in regenerative organs of male and female. Today, before we go ahead, I would like to have two questions for you. One is, are we prepared, yes or no, for PRP to use in the infertility? One. And second, if not, there are so many cell components in the blood, like mesenchymal cells are there, bone marrow components are there, immunity cells are there, serum is there, cytokines are there in the serum. Then why only PRP? This is a very critical question one should come to your mind. Why this PRP alone we need to use? That is one answer which I would like to give you today. I'll skip now about the endometrial part, but give few lines about the preparation and window period. The preparation of the endometrium to receive the embryo, which is a high quality egg. If endometrium is not good, it cannot receive, it cannot engraft. So we need to find out whether our endometrium is prepared to receive the high quality egg or not. There are no fixed parameters, neither some tests which could be assessed to understand whether the endometrium is prepared to receive the high quality egg or embryo. Now, though there are no ideal tests, but there is a test which is defined in the market by called as ERA, that is endometrial receptive analysis. This test is based on the concept of the spontaneous genetic changes which are taking during the endometrium is getting prepared between the mid-luteal phase, that is 19th or 20th day of the menstrual cycle, expression of certain genes. They have tried with lot of analytic problem, but it is again a vague test. It doesn't give standard genetic expression which keep on changing. So I don't believe on this test particularly, but definitely there are some clinical parameters we could use here, particularly using high resolution sonography. This high resolution sonography will have an exact idea of the using the clinical side of temperature changes in the body at the time of ovulation. The patient has the perception in the body during the ovulation. This is particular follicular development which can be seen with the high resolution. The second, endometrial thickness. Third will be blood flow impedance in the endometrium. And uterine volume. They have a very good causal relationship, but again it is not a definitive which can be understood the endometrium is prepared. So modern managements using standard medical cares doesn't have given us a very powerful understanding of preparing the or failing of the receptive endometrium. Now drugs like aspirin, sildenafil, pentoxifylline or tocopherol or extended use of estrogens. Some of them have used even the physical parameters like acupuncture, neuromodulations, or electro stimulations. But using all these things, they have still limitations. The reason I'll explain you very clearly here, which you should grasp in the mind, that body is not a physical system where you can manipulate like a computer. It's not a physical computer, it's a bioreactor which is responding to various signals, various hormones, various growth factors given at a time to prepare the endometrium in its thickness, in its vascularity, plus the receptive surface of the endometrium by expressing certain integrin like of protein molecules or certain receptors which are adhesion molecules which have a affinity towards receive the trophoblast layer of the embryo. This is very important. If this receptive surface is not having adhesion molecules, then probably a prepared well healthy embryo may go into a rejection. And this can be understood by these various parameters. Role of stem cell is also equally understanding in case of thin endometrium. Why? Because endometrium, being a part of reproductive organ, is very dynamic in a regenerative progress. Not like other organs in the body, but ovary and uterus, they have their bunch of stem cells. Even ovary, in our standard medical care, when we were taught, we have a fixed ovarian pool. It was a dogma once taught to us by Johnson & Johnson. But recently, Tilly and his group et al. Has proved that ovaries had got subepithelial stem cells of the ovary. Similarly, the regenerative power of the endometrium was known to us responding to estrogen and some vascular stimulation to about drugs last 30 years. But still we could not get this endometrium preparation to the extent where we could improve our fertility rate on the endometrium resection from 30 to 40 to 90%. So there is something gap of the body here which I call body as an bioreactor. So which responds to multiple factors at a time. And this endometrium has a layer of stem cells which is called as a basilis, which responds to hormone and various signaling molecules of VEGF and PDGF. Now these are the factors along with some of the immune cells like T cells, which are H1, H2, regulatory cells, NK cells, macrophages, and bone-derived stem cells, which are coming from the bone marrow at the time where it requires a stimulus for engraftment. Now, and also VACL cells, they play a major role. Now, this part of the stem cell is not taught in our standard textbook, and we play along with some hormones. Definitely they have a role. We are on the track, definitely they have a role. But if we establish a synergy between regenerative medicine and the standard products of your utility in the infertility or fertility rates in the thin endometrium from a refractory endometrium to receptive endometrium can be very well achieved. This is very, very possible and achievable. At the end of the talk, I'll definitely show some of the research papers which claim about this, as well the some of the review papers which will explain you why regenerative medicine plays a role in changing the receptive or thickness of the endometrium from a non-receptive or the endometrium which is not responsive. This part of the which I had already spoken. Now the two questions which I have asked you: are we really prepared for PRP? Yes, no, in this thin endometrium or regeneration of the ovary or in immunomodulation during the receptive period of the endometrial reception. If yes, then I told you why. Now let's pause. If we see, when we want to answer this question, we need to understand the biology of the platelets. Now when we talk of biology of the platelets are the most important popular healing cells in the body. Wherever you get injury, never forget platelets are the one which come to the side first for the healing system. This biology of the platelet comes from the understanding of various cytokines, chemokines, growth factors and exosomes which are placed in the platelets. Now these platelets which are important by chemotactic action because of PDGF as well as hypoxic injury wherever it takes place during the shedding of the platelets are the first to reach to repair the place of the injury. Now how do we work the platelets in case of using the as an therapeutic molecule in case of thin endometrium? Now always remember, whenever we want to use platelets as a molecule in the treatment, never forget any molecule from a biological concept, which is a cell, bioactive protein, growth factors, even platelets. There are critical procedures and challenges to use them as a drug molecule when we are using in the therapy. Though we are using them in the therapy, the most important part to convert them into to use as a drug molecule is preparing them into the pharmacological action because of their quality which we have to maintain when the platelets are being used as a drug molecule. Then consistency, every time when we use, they should have a consistency of the growth factor release. Second, third, most important, the convenience of reproduction, reproducibility, sterility, which play a major role. And every living molecular cell keeps on responding to environmental factors like temperature, handling which they are handling. So we need to have prepared the robust methods. That is the reason there is the biggest limitation when we use autologous stem cells as a single procedure in the using centrifuge technology, where we definitely compromise the limitation, because in case of patients which are having thin endometrium, they have do definite some morbidity, may be related to metabolic disorders, may be related to immune conditions, may be related to vascularity, may be related to adhesion molecules, may be related to infection like tuberculosis, anything. The functionality of cell components, whether it's a platelet, whether it's a mesenchymal stem cell, whether it's an RBC, whether it's a mononuclear cell, or whether it's a white blood cells, their quality of physiological action is reduced, because of which the morbid conditions don't qualify to take this platelet for therapeutic purpose. This is the biggest limitation when we use autologous stem cells. Remember, even if we take the platelets from an autologous patient, the standard procedures which we use in the preparation of platelet concentrates, which are various ways of physical methods or enzymatic methods. The quantification of platelets is always mixed with other cell populations like white blood cells, RBCs, which definitely affect on the functional status of platelets when we use a centrifuge, whether we use two-stage method or a single-stage method, using a Buffy code, or which is called as a soft run, is a slow centrifuge or spin, and a fast spin or a hard spin. Whether in both the methods, if somebody is interested to discuss on this topic, you can personally call and connect me. In both the methods, there is a possibility of using other cell components, which will lead the effectivity, the already morbid platelets, then because of other cell components, the functionality of the growth factors which they are going to release. So autologous platelets has the biggest limitation because of this. The second most important limitation, as I told you, consistency. We won't get consistent same quality of platelets, same quantity of platelets, because manipulation will change. The quantity of platelets per ml will change. The pharmacological dose normally in the platelet when you use as a therapeutic molecule has to be 5 to 6 times concentrated than a physiological dose of a platelet. Physiological is 2 to 5 lakh platelets, and when we talk of pharmacological dose, it is 3 to 4 million platelets, and they are morbid. They are not equal consistently produced. So don't expect consistent results. Then sterility, which plays a major role. In fact, sterility, because of open methods, when most of the doctors are using autologous platelets, there's a chance of contamination from the environment, from the manipulation who is handling, from the way it is being logistically transported in the OT, from the prepared tube to the tubes or syringes where they are injecting. There are a lot of chances of contamination, and this contamination again plays a major role not to respond of the quality which platelets are supposed to respond. These are very strict limitations when we use autologous platelets. Also more important when we use platelets from an autologous patient, the convenience of repeated every time phlebotomy to collect the peripheral blood. Patient is inconvenient. It is a painful procedure. This is again a limitation for using autologous procedures. Then every time you use, the consistency of the count of the platelets will not remain the same. Also, when we use a centrifuge, the centrifuge times of 4 minutes and 8 minutes or 15 minutes, which you use a soft run and a hard run, even if it varies by half of 15 seconds to 20 seconds during the procedure, you may lose a lot of platelets. It may get contaminated with other type of cells like mononuclear cells, white blood cells, WBCs or RBCs. Again, the effectivity of the platelet is reduced. Having known so much limitations, still if we use autologous platelets, the rate of failure in refractory, which is already we call as a refractory endometrium, the chances of response are reduced. Further, to add you wonderful part is that the patients which come to you, they do have a morbid conditions like diabetes, hypothyroidism. Do you think these morbid conditions will allow the release of quality of growth factors, the concentration of growth factors, which we expect as a pharmacological dose, which I already mentioned, it has to be 5 to 6 times, that is millions, 3 to 4 million platelets. Now, when we use autologous platelets, the quantity is reduced, quality is reduced, infection chances are there, plus the releasing of the growth factors where we target them to be in action is also not in your hand. That is dose calculation of the growth factors, which we expect, like VGF, which is important here for angiogenesis, vasculogenesis, which is very important, VGF-A. Then there is a factor called as PDGF, 3-4 type 1 to 3-4. Then there is a factor like FGF, basal, EGF, and also fibrin plays a major role. Now, in case of morbid patients, the fibrinogen or fibrin, which is making these platelets as a scaffold to hold the other healing cells, which are pulled by platelet growth factors during the healing phase of regeneration or the endometrial healing, and getting the endometrial thickness is reduced because fibrin is also less. Without fibrin, platelets cannot act as a scaffold. Now fibrin, the growth factors, they are having lot of important role as a pharmacological molecule when we use them thin endometrium, as well as their antibiotic action. Platelets do have antibiotic action. Platelets do have proliferative action through their various growth factors. They do have one more very important immunomodulation. 30 plus factors are secreted along with the alpha granules by a platelet. So we don't have any control, as I said you, quality, quantity, infection, release of growth factor, dosification which is required. And now this dosification, quality, quantity, you may ask me a question, Doc, how do you decide in such patients? It's a very wise questions you have asked me. Suppose you ask me, it is very important. We need to consider 3 important criteria. If you want to see platelets go in a success for regeneration of the endometrium, that is in refractory cases. 1, the age of the patient. 2, repeated pregnancy failures, how many times, in which centers they have gone, what type of platelets were used. They all play a major role in the history. And 3rd and most important, morbid conditions. What are the morbid conditions? We need to focus from morbid conditions to take care of, to improve the platelet action, like diabetes, hypothyroidism, lifestyle modifications which we use in the dietary programs, or proper sleep, or proper nutritional products, or where there are certain food items. If somebody wants to discuss with me subsequently after the Facebook page, they have my numbers or email addresses. They can definitely communicate with the lifestyle modification for the food particularly, along with which affects the platelet quality. Now these are focused limitations of the platelets as an autologous. One more thing which I would like to bring to your notice, how do we standardize every time when we are using autologous platelet? Ask yourself a very difficult question. There is no process by which we can standardize. This is very important. Each batch what we use and its subsequent cycles, we need to have the same growth factors, we need to have same sterility, so we need to have same quantity, we need to have same kind of delivered relatively effect of the growth factors, which you will not have in autologous platelet. Also frequency of applications, when we want to take during in one cycle 2 or 3 times. Some of the refractory endometrial protocols which we will discuss whenever you want to discuss with me during the refractory period, you may have in one cycle to use twice or thrice. Every time you have to do a phlebotomy. Don't you feel it's a challenge which is not possible for every time to bleed the patient? The standard is lost, the quantity is lost, dose is lost, infection is a possibility. So all this having a problem in using the standard properties of autologous stem cells, which is challenging to use autologous. Whereas when we use lyophilized, what is lyophilized platelet? Lyophilized platelets are the GMP grade using cryotechnology and using the sublimation technology, using graded freezing technology in a GMP grade to and sublimation to a powder form, that is amorphous or crystalline form. Now there are very many questions. How do we standardize? When I said you, when we want to use these biological products, particularly the prepared from the platelet as a cell or as an biological molecule in the form of growth factors or exosomes or cytokines, which are in the alpha cells of the platelets and cytoplasm. There are many other molecules like mitochondria and all those have some type of genetic material. We have to remove all those cytoskeletal material which are belong to the histone group of proteins. Now when we prepare this, We also take care of high-grade monitoring during the lysis of platelets, where the entire cytoskeleton, which carries antigenic protein belonging to histone group, which has got other organelles like mitochondrial and small molecules which are important for a genesis of the platelet. These are small organelles. These all are removed by the process of centrifuge using three kind of technologies. Normally, when you have been practicing this science, you have come across the procedure which is called as activation. What do you mean by activation? Activation means to release all these molecules at the site or before we use clinically in therapeutic purpose. So various methods are used by using physical technologies, various type of lights or lasers, then frozen and thawing technology or shaking technology. These are various methods which are used, but all methods, they don't standardize to release the growth factors. That is what the biggest limitation for using autologous stem cells. Now here we use a standard procedure which is using thaw and heat and thaw and freeze, which is a very good technology where we don't use any kind of calcium chloride chemical or a thrombin molecule or from the bovine thrombin molecules. We don't use it like, which has got again a chance of contamination and decrease the quality of the growth factors. So using thaw and freeze technology, we have standardized the temperature at which we have to thaw. We have to standardize the freezing point where the maximum highest in 3-4 parameters of thaw and freeze we use to come out the maximum release of growth factors, and that particular standard temperature and standard temperature of thaw and freeze we utilize to have a fixed release of growth factor. That is the first criteria in the lyophilized. GMP grade indicates the complete parameters of sterility using entire profile of viral testing and bacterial testing, and even testing for the what do you call those I'll tell you the moment I remember it, that viruses, bacteria and fungi, even fungi, all those tests are done. This again second most important parameter which we overcome from the standard practice what most of the people are using, most of the infertility experts or gynec are using autologous stem cells. Here what is more important? One is standardization of activation to release all the growth factors, all the cytokines, all the exosomes. Second, sterility, what I have, which in a standard medical care is a challenge because we use all the open methods. There are kits, definitely, but still the kits don't give guarantee of same quantity of release of growth factors. Now, the third most important parameter which I was talking to you, consistency. Fourth, convenience to the patient. We don't have to bleed every time patient. When in one cycle we are using lyophilized, standardized, quantified dosing platelet growth factors, that is lyophilized growth factors, that is no chance of having any contamination. Then standardization, quantification which is important, and dosification I said you. So we can decide specific dose of growth factors. These factors of quantification and quantification as well as dosing depends on three factors when we use. Again, I repeat for all the clinicians when they are practicing regenerative medicine, they're in the clinical rooms, that age of the patient, we need to have dosing very important. That is activation, how much growth factors are to be released. Types of growth factor to be released, like VGF we want more, PDGF we want more, EGF we want more, FGF we want more, thrombin we want more, fibrinogen we want more. If we don't have proper combination of this, the scaffolding property of the platelet is lost, which is achieved here in lyophilized PRP, because these quantifications and fibrin, which are quantified here to give the dosing and scaffolding required to hold during the healing process of the healing cells, which like MSCs, mononuclear cells, macrophages which come. These scaffolded growth factors hold them at the site of healing. See the benefit on about the autologous platelets of the lyophilized PRP. Then, as is more important, the morbid conditions of patient, we don't require to look in, because these are healthy, most standardly prepared platelets from donor platelets, from which single donor these platelet concentrates are prepared. Then we have the most important part in this is each batch, when you are using to each cycle, is standard for your dose, standard for quantification, standard for releasing at the site where you require the action like a scaffold of the growth factors for proliferation, angiogenesis and immunomodulation and antibiotic action. All these four. The frequent application, if you are requiring sometime frequent application, again, it's just a hand to use, like off the shelf vial which contains these growth factors, which I explained already the quality. You have to just don't have to bleed the patient or phlebotomize the patient. And the most important part, in spite you have repeated use, these platelets are immune free because there is no antigen, any of the cytoskeleton which is already removed from the wall of cytoskeleton of the platelet, along with all the microorganelles of the platelets, that's like mitochondria and other organelles, which are already excluded during the process of manufacturing or making these platelet concentrates. In standard procedure, we use both like hard spin and soft spin, where we chances or enzyme technology in the lab. And having enzyme technology in the lab is a huge investment, where again we don't have standardization, procedures of the standardization. So there we could understand why we should look lyophilized PRP to use in such cases of refractive thin endometrium. We can overcome all the causes which cover up for refractory endometrium when we use like proliferation, angiogenesis, sterility, the fibrosis sometimes because like Asherman or repeated infections which has taken place, then having the adhesion molecules on the surface and getting the optimum criteria of thickness, which is a cutoff point around 7 millimeters to have a maximum engraftment in thin endometriums during this window period of engraftment, where we expect to have the engraftment to take place in spite we have a quality egg or an embryo. Now, having understood the difference between autologous and lyophilized or the PRP which is crystalline or amorphous, you may have a wide questions in your mind using this kind of platelet. When I already spoke to you, when we use biological particle or a molecule, these certain critical criteria which are very important to have in using as a standard: quality, quantity, sterility, then consistency, then repeated use, and quantification and convenience, and robotic technologies to have a mass manufacturing, mass production. Now, in case of autologous, you can't go mass utility for 4 times. You can't bleed every time, keep on bleeding the patient. Patient will have an inconvenience, which you have to conceal the patient every time. Why you want to bleed? Here you overcome all those factors. So, these are certain benefits which I think I would ask my all fellows gynecologists, infertilities. I am not a gynecologist nor an infertility expert, to add certain more in standard medical care. But I'm very confident when we use standard medical care in synergy, in lower doses, and use the regenerative technologies of platelet, why not autologous, why allogenic, that is lyophilized PRP. So I answered your both questions. One is why platelets, why lyophilized, and are we ready to use platelets in our clinic, yes or no? So my dear friends, if you come across now questions to ask me regarding various region technologies using of platelet concentrates, auto or allo, why this over that, you could very well ask during this question and answer session. I'll be very happy if the questions comes right away, or even on an email, or you can call on my mobile, where I can give you beautiful, precision made, personalized, customized protocols, because they all depend various factors. I said you, the age of the patient, morbid condition of the patient, and repeated failures because of what infections or stage of the disease you can call. So we can customize you, we can standardize you, and we can precise those protocols for specific indications and give you guidelines for improving your fertility rate from 30-40 definitely to 80-90%, even I would say 95%. There is no reason for a woman who is blessed to conceive a baby by nature to have a blissful life, she should remain infertile. Because when we go at a molecular level, we can find out unexplained reasons in infertility and use these kind of cell technologies, platelet technologies, regenerative medicine technologies, or lyophilized platelets to overcome these failure rates. I'm really thankful for the entire team of mine who could bring me to you today to work up on this small protocol designed for using platelet-rich plasma in the lyophilized form, and how it can be more effectively used and reach to you. Special thanks to my IT team who have taken efforts from 𝗥𝗲𝗳𝗿𝗏 and also I'm grateful to for all the participants on today's digital platform. Though it is a COVID period, the digital platform has made us to come together and learn more the innovative science. Thank you for patient hearing. There is a time which I am dedicating some for your question and answer sessions. We can take few questions as per the time what's limited. Thank you once more. Siddhi or Mani or Tyaga, you can take the questions and forward to me if there are questions.
Yes.
Are there any questions? Ask the question. Let the question be taken. If there are questions. Are there questions? Fine. Thank you for patient hearing. If anybody wants to communicate with me, my email address and contact numbers are given. Please, I'm really happy to communicate with you. Thank you. Next session will be the next week on very special topic for all of you, which will be on ovarian regeneration. Thank you.